Since Pam's here, we can now record the lecture. It's good to go, right? You're what? Asking Simon where he was? TMI. Okay. Again, the distinction between hypoxemia in the blood and hypoxia is at the tissues itself. I'm very particular about using those two terms separately. There's some reading, one of the chapters in Egan, where they kind of use them interchangeably, and it's like, no. That's a bad thing to do. But there are 4 different types of hypoxia that are present. One is going to call, we'll go through these individually, but hypoxic or hypoxemic hypoxia, where the primary cause is a reduction in PaO2, leading to the tissues not having sufficient enough. Anemic hypoxia, which has to do with reduced hemoglobin, let me change that. How about reduced functional hemoglobin? Circulatory, reduced cardiac output. And histotoxic, cell death. I'll just call it that. We'll go through these. First one is hypoxic hypoxia or hypoxemic hypoxia, and this is where tissues don't have sufficient amount of oxygen to do metabolic function because there's not enough in the bloodstream. Plain and simple. It's really easy. So for that reason, then we have to rule out the cause of hypoxia. And there's really 5 of them, if you will, as far as a cause. The first one is something which causes that alveolar value to be reduced. And if you remember back what the alveolar air equation is, right? Vaguely remember, you probably should remember that for like Monday or Tuesday. Probably would be a good idea. I'm just going on a limb here and saying. So if any one of those are reduced, if the barometric pressure is low due to being at a high altitude, if the fractional concentration of oxygen is low, where you're breathing a gas less than 21%, and it sounds kind of stupid, but why would you do that? There's multiple reasons why we would want to create that hypoxemia. Give you a little bit of an example. In a former lifetime, I worked for a company, Nelcor Puritan Bennett. Nelcor manufactured pulse oximeters, those things they put on your finger, you know. And when they would go through testing, they would have healthy volunteers come in, and they would have them breathe oxygens at like 15, 17% to purposely create low PaO2s. It's called the breathe down lab, and they could see how accurate the pulse oximeter was when you're in these extreme conditions of severe hypoxemia. Then they'd bring them back up and send them back to work. It was like something just wrong about that somewhere along the way. But normally we don't breathe gases less than 21%, but there are instances where we do. And then the third thing, the factor that is involved there, so we got the barometric pressure, the FiO2, and the PaCO2. Hypoventilation is a cause because we drive up the alveolar level. We can't go ahead then and have as much oxygen, P capital AO2, as well as P small AO2 then. So causes of hypoxemia can be elevation in altitude, hypoventilation, breathing a gas mixture less than 21%. Chances are the first and the third one you're not going to counter unless you're working in an environment where, you're working in Denver or something. But, on a day-to-day basis, it's not going to be a cause. Hypoventilation is quite a common one. Diffusion impairment is, we talked about, that the hypoxemia is secondary to the fact that there's a distance, either a reduction in, let's go back and talk about it. I probably shouldn't just make this leap of faith there. Fick's law of diffusion, or the 2 big factors involved. Okay, how about surface area? And the second was thickness. If I do anything to widen that alveolar capillary distance, say by accumulation of excess fluid in the interstitial space, say because the preload is excessive on the left side of the heart, a high wedge pressure drives that, creates a heart failure condition where the left side can't pump out the blood and it backs up into the pulmonary system and floods the alveolus. We also know that we have a diffusion impairment whenever we lose functioning alveoli, as you would see with pulmonary emphysema. You end up seeing a diffusion defect. Usually this doesn't manifest itself except during exercise or activity, if you will. I say exercise, but hell, exercise could be something as simple as walking to the bathroom. Yeah.
It's really hard to see.
Yeah. No. How's that for an answer? I've called them. The only thing I could do is turn off the lights. Try turning off the lights and see if you guys can still take notes. I don't know. You tell me. I've called them. They know the bulb is dim.
Yeah.
You're okay?
Yeah.
Okay. It's in the process of being repaired. My apologies. So again, during exercise or any kind of activity, that's when you'll see hypoxemia developing with a diffusion impairment. We talked last time about intrapulmonary shunting and calculating the shunt equation. But that's one of our causes that we'll see, especially in the ICU. The most common cause of hypoxemia, however, is simply ventilation perfusion impairments. And we talked about this one being the one that is refractory to conventional therapy. Pretty much all the rest of them, well, let me rephrase that. This one responds well to O2. This one responds well to O2. This one, you just got to ventilate them. Reverse the process. Okay. Okay, so that's hypoxemic or hypoxic hypoxia, type number 1. Type number 2 is anemic hypoxia. And anemic means that we have insufficient amount of hemoglobin, or what hemoglobin is there is defective. This is a situation where the arterial value, the P small AO2, is normal. The problem is not that the oxygen level is low. Follow me there? So I could have just simply a reduced hemoglobin, and my hemoglobin level is equal to 7.0 grams per deciliter. Well, that's a low level. I could be hypoxic at the tissue simply because I don't have the carrying capacity. My oxygen content would be drastically low. We can have the same exact problem with a normal hemoglobin level. Say my hemoglobin level is 14 grams per deciliter. Males or females, that's a good number. However, there's a significant amount of hemoglobin that has something other than oxygen attached to it, or is unable to carry the hemoglobin or the oxygen. First one I want to mention is carboxyhemoglobin, where the hemoglobin molecule is bound with carbon monoxide, CO. Carbon monoxide has 245 times the affinity of hemoglobin as oxygen. So if carbon monoxide's in the neighborhood, I don't care how much oxygen you have present, CO is going to win. Carbon monoxide causes a leftward shift, which means that there's an attempt by the body to have an increased affinity for oxygen. It's trying. Normally, under normal conditions, it is a byproduct of metabolic processes, and you have a small, less than 3% value in the bloodstream. By the way, the symbol for this saturation of carbon monoxide. When someone smokes a cigarette, there's an increase in that value. Carbon monoxide is one of the byproducts of combustion. So there is a reduction in oxygen levels or an oxygen carrying capacity simply because of the cigarette smoke. One of the problems why we try to encourage pregnant moms not to smoke. One of the many. You start getting severe toxicity at 20%, and it's lethal at 50%. And this is the time of year where we end up seeing carboxyhemoglobin situations coming into the ER. And it's usually because the furnace goes on the fritz, and you have carbon monoxide leaking back into the house. Also, anytime you have any kind of internal people doing stupid things like lighting heaters and whatnot, propane heaters that are designed to be outside the house, using them inside the house and without proper venting, you could very quickly get levels of carboxyhemoglobin which are lethal. Treatment is 100% oxygen. So even though my arterial PaO2 may be 400 torr, 100% oxygen. The only way to push the carbon monoxide off the hemoglobin is to have a very high partial pressure of oxygen, which means that we may need to even use hyperbaric treatment. Okay. But you're looking, just simply put them on 100% reduces the half-life of carboxyhemoglobin by from 5 hours breathing room air to 20 minutes. So as soon as possible that we can get them on a very high concentration of oxygen, have them breathe that for a short term, pushes it off. Yes?
So, referring back to the oxyhemoglobin dissociation curve,
Mm-hmm.
Since this
Carboxyhemoglobin. It's okay.
it's early. So since that causes a shift to the left, it's not only associated with just saturation of oxygen.
What it's saying is basically, I know that I got this nasty carboxyhemoglobin floating around. What hemoglobin I have that's not with that, let's make that affinity even higher. Let's bind as much as we possibly can.
So oxygen is going to bind more to the hemoglobin.
It's going to try to,
carbon
yes.
monoxide attached to it.
Well, no. Let me make sure I'm clear on this. So here's my hemoglobin molecule. I have 4 COs there. There are other hemoglobins that were reduced that now have a higher association for oxygen.
Oh, so more oxygen is going to attach to one
The
more.
hemoglobin that is reduced will have a greater affinity, will have a greater tendency to bind with oxygen that's available.
Okay.
And what you'll end up seeing is the hemoglobin, carbon monoxide being, if I use the same symbol that I just used, the saturation of carbon monoxide being 20%, well, that means that the most you could have for oxygen would be 80%. So obviously it cuts into what you have available. That level falls, oxygen content falls, oxygen delivery falls, potential exists for those tissues to become hypoxic. Got it? Okay. Carboxyhemoglobin. Methemoglobin. Methemoglobin is a variant of adult hemoglobin, and it's one where the iron is not in the ferrous state, the +2 state, it's in the ferric state. It's icky. And because it's icky, it don't worky. It can't carry oxygen. Okay? It just is dysfunctional. Normally there's a very small percent, less than 1%, 0.5%, somewhere in that area, that we end up having. Just again, normal metabolism creates a small variant that is present. Where we see this increased is with nitrate ingestion. So anytime we have any nitrate being administered, excessive use of nitroglycerin as a vasodilator, there's a medication that we'll find, and for right now you don't need to know this, but a medication called nitroprusside or nipride. Nipride is a very, very potent vasodilator. So if somebody came in blood pressure 210/190, You wanted to lower that blood pressure quickly. Nitroglycerin and nitroprusside, both of them would drop that pressure to a safer level so the person doesn't stroke out. The problem is that the use of these drugs can lead to the conversion of hemoglobin from the ferrous to the ferric state. It's kind of a nasty side effect. Some topical anesthetics can end up doing that also. And we treat it with methylene blue. It's just a substance that we go ahead and administer, and it will reverse that ferric to ferric. It will reverse the hemoglobin that is in a ferric state back to a ferrous state and make it functional once again. So again, I can have a hemoglobin met or a saturation met that is, 15%. Well, that's going to block out how much we can have as far as the saturation of oxygen. Limits the amount that you can have. Because remember, all the hemoglobin has to all the things that saturate with hemoglobin have to total up to 100%. So if I have something else taking up space, I can't have oxyhemoglobin be there. There's also one called sulfhemoglobin, which is basically a complication of some medications that have sulfur as a base to them. A group of antibiotics called sulfonamides that include Bactrim and Septra, which are pretty potent, pretty common antibiotics that are in use. Large doses of them can lead to the development of sulfhemoglobin, and really there's nothing you can do about it. You just got to wait for it to be destroyed. But in the meantime, that hemoglobin is not functional. And then finally, sickle cell hemoglobin. And sickle cell's situation where one of those beta chains, remember we talked about those, there's alpha chains and beta chains within the hemoglobin molecule. It's where one of the amino acids on the beta chains is altered, and it's a inherited disorder, typically seen in African Americans, where during a crisis, which is what ends up happening periodically, is these hemoglobin that are normally nice concave discs become literally like spears. And they end up basically clogging, causing strokes, causing other issues, extreme pain, leading to infections, all kind of processes. But obviously when they're in this fashion, they're not in a normal shape. They're not able to carry oxygen in normal fashion. So again, another problem with oxygen transport. So carboxyhemoglobin, methemoglobin, sulfhemoglobin, sickle hemoglobin are all instances where oxyhemoglobin is reduced, oxygen carrying capacity is reduced, and you potentially have the development of hypoxia at the tissue. So those are all anemic hypoxia. Don't be fooled by just having anemic hypoxia thinking, oh, it's got to be the hemoglobin level being low. It's more than that. It's abnormal hemoglobins also. Circulatory hypoxia, as the name implies, is basically where we have inadequate oxygen delivery or oxygen levels, second to reduced delivery. It's not so much the CaO2. If you remember, the formula for oxygen delivery is oxygen content times cardiac output times 10. So in this case, it's not so much this being the problem, it's this being the problem. And it's reduced cardiac output, reduced blood pressure, secondary to reduced heart rate, reduced stroke volume. We know the three determinants of stroke volume. Right? Sure, Rick, whatever the hell you say. Okay. So we need to figure out which of the what's causing the reduction in blood pressure, reduction in cardiac output, fix that. It's not, again, situation, normal PO2. It's not necessarily a problem with oxygen getting across the alveolar capillary membrane. It's a problem someplace else. And then finally is histotoxic hypoxia. And this is one where the mitochondria itself, where the oxygen is being utilized to create ATP as energy, that mechanism is disturbed. Even if you have, again, PaO2 normal. Even if you have a ton of oxygen available, it just can't use it. The mitochondria have basically shut down, and their ability to actually use oxygen and create a normal oxidative metabolic process is eliminated. One of the causes of this is cyanide poisoning, and you think to yourself, well, geez, who's going to take cyanide? As you'll find next semester when Jeannie talks about patients who are in fires, cyanide gas is a gas which is created whenever plastics burn. Gee, do you think there's plastics burning in a house? Quite a lot. So this is a situation where removal of the person from that environment is necessary to reduce the cyanide gas and therefore reduce the histotoxic hypoxia present. Okay, so again, going back to our 4 different types, hypoxic or hypoxemic reduction of PaO2, anemic, functional hemoglobin's low, either as a raw number or because of those odd hemoglobins being present, low cardiac output causing circulatory hypoxia, and problems with cellular metabolism for histotoxic hypoxia. All right. I don't know if Ray or Jeannie have talked about cyanosis or not, but let me just make comment on it. It's, again, a bluish discoloration of the mucous membranes or the nail beds. And it can either be peripheral cyanosis or central cyanosis. Peripheral cyanosis, as the name implies, is just usually the fingertips and toes are blue. You can see this with Raynaud's syndrome, where there's a reduction in perfusion to the of the vasculature in the periphery. Central cyanosis is obviously the more important one that we're going to focus on. It's where the mucous membranes around the lips, the nail beds, they're all bluish in nature. And this is present when 5 grams per deciliter of hemoglobin is unsaturated. And usually this correlates with a saturation of somewhere around 85%. So it's going to be a pretty profound drop in PO2 and saturation before you start seeing the patient appear cyanotic, meaning it's a late sign. And anemic patients, they're going to look pale. In a lot of cases, they can be profoundly hypoxemic and they do not look cyanotic. So cyanosis is a sign that you'll see that tells you that the patient is hypoxemic, but you got to be careful using it. If you're waiting for them to become cyanotic before you intervene, you're waiting too long. In addition, those patients that are polycythemic often will be cyanotic when they're not necessarily hypoxemic. So patients with extreme end-stage lung disease who have hemoglobins of 18, 19, 20 will appear cyanotic, but their PaO2 really is not that bad. Oh, speaking of which, we just talked about this. The development of polycythemia, whenever you see that word, think chronic hypoxemia. It's the body's response in the presence of hypoxemia. A hormone is released called erythropoietin, which goes ahead and stimulates the bone marrow to produce additional erythrocytes and, by definition, then hemoglobin. The increased hemoglobin is there to basically say, okay, let me carry more, but it also increases the viscosity or the afterload, which puts extra work onto the heart. One of the other things that chronic hypoxemia will cause is an increase in pulmonary vascular resistance. And we talked a little bit about this when we were talking about afterload on the right side of the heart. The development of that cor pulmonale, where you have increased right ventricular mass. You have chronic pulmonary vascular resistance being increased, pulmonary hypertension. And that's, again, a side effect of the chronic hypoxemia. Just make mention of fetal hemoglobin, hemoglobin F. That's what's present within the developing fetus, especially during the latter parts of the pregnancy. It's the transport mechanism. Has a P50 of about 20, which, if you remember back, a very low P50 means a huge left shift, which is good because the normal PO2 in utero is somewhere on the order of about 25 to 30. So mom transporting oxygen across the placenta into the baby, it's not a real great system. I mean, obviously it's good enough that we all ended up here, but there's a very drastically low arterial PO2 present, so that we end up having to have a hemoglobin molecule that has a huge affinity for oxygen. And towards the latter portions of pregnancy, we start developing hemoglobin adult, and there's that hemoglobin F just kind of goes away. Key part to remember is that it doesn't turn into the fetal hemoglobin doesn't turn into adult hemoglobin. It basically just adult hemoglobin starts to become manufactured, and the hemoglobin F just kind of gets destroyed in the normal process. And usually by about a year, that is entirely turned off. There is some pathophysiologies, you don't need to know it yet, but where that process doesn't stop, and whether or not this is related to SIDS or not is up for debate. And we will start next time with a demonstration of Thomas the Tank Engine and an explanation of hypoxia, for those of you who might remember Thomas the Tank. Okay. We do this first.